are very prominent faculty, women faculty in Bouvet. Today we will be hearing from Professor Janet Rico, and I will introduce her formally in a moment. But the series is intended to talk about the experience of our faculty, not only in the way that it has shaped their own practice, but also to gain insight on key shifts and trends that are transforming the healthcare landscape, particularly in the present time that we are living. So we really are very excited to have all of you here today and look forward for a very interactive exchange of ideas and questions. Before I introduce our speaker and moderator today, I'd like to introduce Crosby Enright, who is the executive assistant in the Dean's office, who will go through the logistics of the event in terms of the venue we're utilizing. Crosby, please.
Welcome again, everybody. As we settle in, we just wanted to share a few best practices and notes for this event. We are recording this, and the recording will be circulated afterwards. We ask that if you've joined from another device, such as an iPhone or an iPad, if you could please try to rename yourself, listing your first and last name. We would greatly appreciate it. And then we ask that you please remain on mute unless you are called to speak. You're welcome to leave your webcam on for the duration. It would be great to see everybody's faces. However, you do not need to. And in order to raise a question, make a comment, we encourage you to please use the chat window. You can type your question or comment there, and then we'll address it in the order received during the open Q&A portion. And if there are any technological questions, issues, please also feel free to put them in the chat and I'll help address. So then, thanks again.
Thanks, Crosby.
Thank you, Crosby. So without further ado, it is my pleasure to introduce Professor Janet Rico, our speaker today. Thank you, Janet. She is the Assistant Dean of Graduate Nursing in the School of Nursing at Bouvet College. And Professor Laura Mylott, who will be our moderator today, is a clinical professor and director of nursing leadership in healthcare delivery and informatics. And so Laura will be moderating the session. You will not see me at the end. You are in great hands, but I will be here and listening and participating. So Laura and Janet, please take it away.
Thank you, Carmen.
Thank you, Dr. Skepa. Welcome, everyone. I want to just take a moment and build on the introduction Dr. Skepa gave for Dr. Rico. Dr. Rico is currently a practicing nurse practitioner who's certified in both family and geriatric specialties. She's a member of the Executive Board of Directors for ARC, a national advocacy group for individuals with developmental intellectual disabilities and autism, and a member of the Board of Directors of Fallon Healthcare of Massachusetts, where she has the opportunity to really uniquely advocate for both quality healthcare and healthcare delivery conditions for patients and healthcare providers. Lastly, I just want to mention Dr. Rico also brings to her really effective advocacy, the personal experience as the mother of a daughter with adult learning disabilities. So, Dr. Rico, I think our format's been explained by Crosby. We'll start with a brief overview of our topic, community nurses, caring for the most vulnerable community members through COVID-19. And then we'll host a question and answer. And at that time, if you really would like to speak as well, you can just indicate in the chat box that you'd like us to unmute you. So I'll turn it over to you, Dr. Rico.
Oh, thank you, Dr. Mylott. Well, thank you, everyone, for coming to have a discussion about community care for the most vulnerable in the setting of COVID. This is really my passion, improving the care we provide to our most vulnerable in the community. And I want to thank Dean Shepa for giving me this opportunity. I have to say I was really excited to be given this chance because it is my passion and something that I really feel we need to, our society really needs to work on. I'm honored to be given the chance to talk about patients, nurses, and the current community care environment, which have inspired me to help make it better. the pandemic has actually made me also realize how grateful I am for the small things in life. And I have to admit, Jennifer, when we were planning this, I was kind of glad that it was put off a few weeks in June so that I could have repair of my self haircut and color, which was a disaster. So it was kind of nice to be able to go to the hair salon last week and get my hair done. That was just a small thing, although I'm very grateful that I have that opportunity. But those are the things that just getting your hair cut even, or going out and seeing the neighbors for a walk, you know, after work instead of being on the train. I have to admit there've been some, I wouldn't say bright spots, but just appreciating the smaller things, which have given me a lot of time to reflect. So at any rate, after I was invited to present, I began to think a bit more about the word inspire. And although I don't particularly see myself as inspirational, I began to think about others who inspired me. And the word inspire comes from the Latin word inspirare, which I never really thought about it being a nurse practitioner. You think I would have, but inspiration. And it really means to inflame, excite, or breathe into. And the patients I have cared for and the nurses I've worked with and interviewed for this discussion have indeed done that for me. Their stories have inflamed me to action, they've excited me, and provided a breath of fresh air, ideas about how best to create a more efficient, compassionate, and effective and supportive community care system. And it also highlighted something I already knew, that nursing truly is powerful, and it really is the answer for many of the things that we're grappling with in healthcare today. We work on improving access, we work on coordination of care, early and ongoing assessment and management of chronic diseases, maintenance of health and wellness, palliative and end-of-life care, health education, disease prevention, and of course, most importantly now, infectious disease monitoring and tracking. So my objective today is to highlight the role of the community-based nurse during the COVID-19 pandemic. And these nurses work in a variety of settings that sometimes are, I wouldn't say forgotten, but not given a lot of really priority in our system. And of course, as we all know, nursing homes are one of the biggest, assisted living facilities, group homes for individuals living with intellectual and developmental disabilities and serious mental illness, homeless shelters, homeless medical respite centers, prisons, schools, and of course, home care and hospice care. So to set the stage, what is community nursing, you might ask? And you know, I had to go and look it up myself to see what the formal definition was. And I'll actually tell you, I don't really agree with it. It's from the American Nurses Association. And their definition is that it is a synthesis of nursing and public health practice applied to promoting and preserving the health of populations. And the only thing I don't like about it is that we really need to also be giving attention, again, to individual care. And that is a big piece of what community nurses do. A community nurse combines elements of primary care and public health practice outside of the hospital setting, or what we also term tertiary care. Why do I want to shine a light on this subject, and why is it important? Well, my practice has been across all transitions of care as a nurse practitioner. So I've worked in home care with a geriatrician, in rehab, long-term care as an NP, clinic settings, emergency departments, and now in hospital-based care. My work as an NP every other Saturday at Mass General in the emergency observation unit has actually even more highlighted the need for strong community care services. When I work on a Saturday, I'm admitting a lot of patients. They may be going to the floors. They could be, unfortunately, going to the ICU, and some are discharged home. But on any given Saturday, there may be a frail elder or maybe a few people who can't be discharged because there's not access in the skilled nursing facility, or an individual who is without a home cannot be admitted to a place where I feel they're doing God's work, Barbara McGinnis's house, which is run by Boston Healthcare for the Homeless. And there's only so many beds. And so those are some of the struggles that I grapple with at work. Or also just feeling, even though they've been cleared, physical therapy says they're okay, I've done their med reconciliation, I've written the plan of care for home, I just have this this gut feeling that I just feel that they may not be safe within their home. And so what do we do about that? And there's just rising numbers of people that are in this situation. The other reason that I'm so passionate about this subject is that I've lived it. I was the mom of a 28-year-old woman with significant developmental and intellectual disabilities, about 6 months old developmentally, who was 24/7 care, and had increasing worsening medical complexity over the last few years. She required intense nursing care within the home. And I'll talk about this a little bit later, but it was extremely hard to recruit and train staff for my home. I was blessed that I was able to do this and able to stay in my job, which I so love, and been able to also do my policy work. But frankly, there are a number of other families, many families, that are in the same boat, and it's something that we need to really look at. My volunteer work, as Dr. Mylott has said, involves some board work with a healthcare an advocacy group for people with intellectual developmental disabilities, where our priority, as I chair their steering committee as well, is at looking at the workforce for direct service providers, but also medical professionals who can take care of people with significant disabilities. And my work with Fallon Healthcare, I also chair their service and quality committee, where a lot of the discussion revolves around coordination of care, care for people with significant mental illness, and all the things, the complexities that we're dealing with in healthcare, which again, I feel nursing really can very much be the answer to. I'm also doing volunteer work with the state, working on the personal care attendant workforce council, and also the Attorney General appointed position with the Mass Personal Care Advisory Committee, where we're working on policies and recommendations to the state about how personal care attendants, which are the glue of how people can live in the community with disabilities and frail elders, how they can stay out of hospitals and how they can stay out of institutional care and live and have quality of life in their homes. And so this work has really informed and inflamed me, as I might probably say. Flamed isn't really the right, but actually it is the right word, I think. And so why else? Well, there's a shift in the demographics, and frankly, I'm part of it. I did obviously just previously tell you that I do color my hair, and I'm also one of those baby boomer generation folks. The increase in this population, I'm not yet 65 and older, but the 65 and older will rise from 52 million, and it's estimated to go up to 95 million by 2060. Now, I've done the numbers, and I think that I could still be alive by then. So we need to get this straightened out. It's only 40 years from now that we would be almost doubling the number of people 65 or older. There's a projected 50% increase in the number of Americans 65 and older who will require nursing home level of care as well, from 1.2 million in 2017 to about 1.9 million in 2030. And another estimated rise in people living with dementia from 5.8 million to 13.8 million in 2050. So that's a little bit of the shifting demographics. We also see that people with significant disabilities and complex medical conditions are living longer. Even though there's disparate care for people with disabilities, they're still getting some of the surgeries that correct anomalies. There's better medications for seizures. We're doing a better job in general in keeping people alive longer. The other factor is the deinstitutionalization of individuals with intellectual developmental disabilities and severe mental illness, which happened a number of started in the 50s, 60s, 70s, but with the civil rights supporting this, the civil rights movement, that these individuals should be able to live in the least restrictive environment possible and taken out of institutions where they should be in the community. However, my advocacy work is supporting the need we're still not where we need to be with long-term supports for these individuals, and again, healthcare. And a lot of frail elders are in certainly the same situation with living with disabilities as well. So you can see just the context of what the community nurses are dealing with. There's a push for elders staying in place, and elders want to stay in place. My dad is adamant at almost 89, he's staying in his house. Oh God, I hope he didn't he might have gotten in, maybe, well, anyway, he's driving me nuts because he's, he wants to go out, and I'm trying to protect him. And anyway, he is adamant he's not going to go anywhere despite all his medical problems. Hospital at home initiatives are rising programs within a lot of healthcare agencies where nurse practitioners, PAs, nurses are going into homes and providing hospital level care, but within the home. And skilled nursing at home. I heard this last week from one of the directors of skilled nursing agency, and I kind of isn't that really great quality home care? And but that's the latest buzzword, is skilled nursing facilities at home. And why are we doing this? Well, first of all, length of stay to obviously cut costs. We don't need to always have people in the hospital for longer than what we used to do years ago, but also nosocomial infections or hospital-based infections, which are rampant. They really are, and they're difficult to treat, and sometimes they're not treatable. And I would put, even though COVID is not a nosocomial infection, people are going to be less likely they're not going to want to go into the hospital, as we're seeing because of COVID. There's just more likelihood of transmitting the virus. So now we have the extraordinary work of these nurses working in community care, which are already understaffed and under-resourced prior to COVID. And that is something that I really wanted to highlight. And that's why I've been interviewing as many community nurses and directors of community care that I could for the past 2 months. And again, already living it in my professional and personal life. As an example, 1 in 7 nursing care positions within nursing homes was open pre-COVID. So now we see the National Guard in nursing homes. I just got an email last week from the Massachusetts Department of Public Health recruiting for certified nursing assistants with a very large bonus. And this brings me back to my passion. My dissertation had to do with certified nursing assistants in nursing homes and the retention and recruitment. So we're seeing this has been a problem, and it's just been incredibly compounded with the impact of COVID. But in some ways, not to try to have positives shown on a pandemic, but it is highlighting the gaps. Just to give you an idea of the number of nurses in the country, just so you get an idea, there's 2.8 million RNs in the US right now, and they're prepared typically at the associate's degree or bachelor's prepared level. And we also have about 690,000 licensed practical nurses. They're called LPNs in the state. They're called licensed vocational nurses in other states. And they typically in our state have 10 months of intensive training. And frankly, they're the glue along with the CNAs in long-term care. It's amazing what they're asked to do. And their training is 10 months. A National Council of State Boards of Nursing survey in 2017 estimated that there were about 32% of LPNs working in long-term care and about 56% of RNs working in hospitals. So to give it now context to what's going on now in the community, more than 2/3, it's been all over the media, I'm sure I'm not telling you anything that you don't know. This past week's, looking at mass.gov, the COVID deaths were 6,547. They are 2/3 of those occurred in long-term care. And an estimated 25 to 30% of group home residents. Now these are individuals, primarily folks with intellectual and developmental disabilities. There are 2,353 homes for individuals with intellectual disabilities in the state. And I couldn't find the data for serious mental illness, but it's a lot less. But anyway, 25 to 30% of those residents tested positive for COVID. There was a lot more testing done, but that's pretty impressive. And over 23% of the staff tested positive. Now, many of the staff in these group homes are direct service professionals. Nursing is definitely involved in group homes. I spent a great amount of time talking to one of the directors who oversees a number of group homes, and we'll talk about that in a little bit. But their jobs were just, I was in awe, and that's the only word I can use, really. So anyway, that's my overview, and I think I will now pass it to Dr. Mylott for some questions and answers that we have prepared. And then, you can always put something in the chat. And if we see it, we can also, interrupt our formal question and answer. There's nothing really formal about this. We want to be getting your questions. And if I don't know the answers, well, we'll find out. And we also would love to have a little bit of a discussion too, because I'm sure that there are folks out there that probably know a lot more about some of these areas than I do. So thank you. Thanks, Laura.
Thanks, Dr. Rico. We do actually have one question in the chat that might be good to address before we move on. And it's from Jerry. And when we say most vulnerable, who does that include? What does that mean?
That's a great question. And, it's my definition of most vulnerable, really. Those are folks that need supports with ADLs and IADLs, so that's activities of daily living, that may have a physical disability, a cognitive disability, a psychiatric disability, or an intellectual developmental disability or autism. So there are folks that are really at risk. And I would say, especially people with serious mental illness have many medical comorbidities that go along with their mental illness, and a number of people with intellectual disabilities also have a number of different medical comorbidities as well. So thank you for that question.
Thanks. Let's stay on looking at community healthcare through the lens of COVID for a bit. You did talk about the existing lack of nursing resources, especially among CNAs in community health. Maybe you can expand a little bit on how the COVID pandemic made visible the pre-COVID insufficiencies and gaps in community healthcare.
Yeah. Well, one of the biggest themes, problems that came out in all my conversations with, again, the many nurses and directors I spoke to, was staffing. And so pre-COVID, I just mentioned earlier about the nursing homes being understaffed, but a lot of other settings too in community care understaffed. And so, so that was a big deal, especially when you have people becoming ill, right? And trying to, staff, or people that were too afraid to come to work, which that's, they're right. If they can't come to work, then they're have high anxiety, they shouldn't be asked to come to work. So that was really a theme that came out of all of the sites, the program for all inclusive care for the elderly, home care, a big thing in home care as well. Just because, especially with continuous nursing, they knew the clients that they were taking care of, and when they weren't there, then they need to replace with another nurse who, didn't know the nuances of taking care of that patient, which sometimes can be, extremely difficult. Training is a huge issue. It always is an issue. It's a big issue for the personal care attendant workforce, and they are not required to have any training to be able to take care of some people that have significant issues. They could be behavioral issues. And so that was the training was even more compounded, because then they had to teach unlicensed personnel how to don and doff gowns, how to take off gloves appropriately, how to be very, very careful when they were, in with the patients, the clients, I should say clients really in community care. So that was a huge issue. And then training families. We can't have you come into the nursing home. We can't have you come into the assisted living or the group home because it's too risky. Well, why? And then training of staff around quarantine if they were exposed, or when they could come back to work. And a lot of this was in the hands of nursing directors trying to gather information to be able to give the right information out to patients, families, and staff. Easy access to expert advice. One of the things that really came through, I was on some of the earlier calls when they were trying to figure out how to deal with this in the group home population with a number of the executives across the state with the group homes. And they were receiving different information from the town's public health departments about what to do. And then they were looking at the CDC, but your first responsibility is to the town's Department of Public Health. So there was a lot of that kind of stuff going on. and just also getting a hold of primary care physicians and providers. Just being able to do that was sometimes a struggle for them. Just in general, resources across community care tend to be certainly less than they are in tertiary care. There's just no doubt about it. You know, and how we prioritize care. And, you know, in our society, it's interesting, when I go into the literature on community care, there's so much coming out of the UK, and yet not so much coming out of our country. And I guess I'll say it, I work at MGH, I love where I work clinically. It's unbelievable there. I just absolutely love, it's just a phenomenal place to work. But you know, the reality is that we're still kind of a cure model of healthcare. And so care is not, it's not priced as much. It really isn't. So I think that's something that, you know, is an issue. And of course, resources for PPE, that was just, so I'll talk about that a little later, but PPE was just, the stories of gathering how to protect people were just really interesting. The feelings of isolation from the staff. So one of the big things, we had a home care symposium last June at Northeastern, and one of the big things for recruitment of home care nurses, one of the barriers was the feeling of isolation. They feel that they are working autonomously, very independent practice, and sometimes with some very, like my daughter, we were talking about protecting the airway and clearing the airway by themselves in the home, by themselves. And but that feeling of isolation and not really being a part of a real team, you know, it's with the family as the team, but not really being part of a team. And we have ideas about how to improve that. We need to work on that. And again, just the societal perception of priority not being community. So, and that's all pre-COVID. So you can, it just exponentially has, and you know, I hate to say this, I think we're going to, no, I'm not going to say it because I already know it. We are seeing, as we mentioned earlier in one of our research meetings about COVID, there are folks that are going to need more intense care now because of coming out of the hospital with COVID too. So you're saved in the hospital. Thank God for our ICUs. And I know how incredible they were in caring for my daughter. But then on the home front, it's like from this incredible care to this steep decline in resources.
Thank you, Dr. Rico. You know, we have some excellent questions coming from the participants.
I hope I know the answers. If I don't, we'll figure it out, and we'll get people together and we'll figure it out together then.
All right, so let me start. I'm going to take them in the order that they're coming in, and this is from Liz Thebe. And Liz, I'm going to read your question, but you know, if you would like to be unmuted, just give us a high sign. So Liz is class of nursing 1979, go Huskies. I live and work in the UK and see the expected roles for charity and volunteer services functioning as a part of the glue to provide services for people to stay in their homes with an acceptable quality of life. How can we better coordinate care with the charity sector?
That is just such Laura, we were just talking about that this morning. When we were talking about, so Laura has a figure that she'll talk about a little later. We're getting all our data together. You know, about the amount of money our country, if we were to look at family caregiver funding for care.
How about I just tell you right now? So AARP reported in 2016, the United States spent an astounding $470 billion. And that was the value of unpaid care provided by family caregivers. So
we don't always like to value things because we don't really want to talk about it because it's going to show that there's a huge gap. But so we were just talking about that and how, you know, creating a culture where actually they're exactly what you just said, that, you know, people, you know, friendly visitors, you know, again, we do Meals on Wheels, of course, but you know, right now I have friends doing that, you know, they need to leave it at the outside of the door. But, you know, once COVID is done, or even, you know, even making calls. I know my church has been doing that, and we're trying to, you know, reach out to people that are vulnerable. But that is a huge, I so agree. And one of the things that our accountable care organizations have been doing are linking up with community groups to, you know, provide enrichment to people that feel isolated and to meet other needs. So thank you for bringing that up. That's huge, and that is a huge answer. It's part of it. It's part of the answer that our culture, I think it definitely has to change, and we have to really acknowledge that. So thank you.
And do you see an expanding role then? So in terms of like the church, the examples you gave that currently play a role?
Yeah, I absolutely do. Yeah. Well, my one of my close friends is actually, I should have put this, you know, thank God she's not on. I didn't mention them, but you know, church ministry nurses, and she is a ministry nurse for her church. And they've been doing phenomenal outreach to frail elders within their community, because it's been a huge problem, huge social isolation. I know even my dad, I mean, it's just been, it's kind of heart-wrenching sometimes. And of course, I can't even imagine being in assisted living or a nursing home and having to stay in your room the whole time. But anyway, thank you for that.
Dr. Jackie Telesco, what are your thoughts on healthcare policy and the emphasis on focusing on quality care to our elders? Will this require increased financial support to our nursing homes and other communities?
Yeah, you know, I think, Jackie, what's happening is I think there will be, you know, as I look at, again, some of my work even on the healthcare board, you know, looking at the way our payments is structured right now is changing. There's and especially for the Medicare population, the Medicaid population too. What we're seeing more, and we will see more of, our MCOs, SCOs, PACE programs, which are dual, typically Medicare and Medicaid funded, and those models of capitated payment, I think, will change how we give care and will incentivize higher quality care. And, you know, we even see that now, that, you know, in the PACE program, you have really bad COPD, for instance, lung problems. You know, you may need you might need us getting you a air conditioner, because we don't want you going to the emergency room. You know, it's not rocket science that the cost of the air conditioner is a lot less than one ED visit. So, is that your question? Was that the question? Pretty much today. She can ask if there's, yeah.
Yeah. Do you have anything else? You're muted. You're muted, Dr. Telesco. Maybe we can unmute her.
Okay, I got it. Hi.
There you go.
I think, you know, ironically, with everything going on with COVID, it's actually highlighted this population, right? The nursing home population and the elderly, and whether or not this is an opportunity to sort of recognize the lack of attention they have, right? Yeah. Recognize. So, you know, it's frustrating to see how, you know, the lack of quality care they're receiving, and whether or not you see all the fundraising going on, and whether or not there's something that could be done for this, you know, population, and maybe more will be, you know, more will be done at the policy level. So that was more what I was thinking.
I see. Okay, great. Thank you, Jack. Jackie's one of our esteemed faculty in the graduate program here at Northeastern, Dr. Telesco. And so, yes, you know, actually the state and CMS is doing a lot right now, of course. If you go online, you can, there's a lot of data being shared with families, a lot more funding coming in. So I do think and also I actually have all the bills, which I wrote down somewhere, but you wouldn't want to know their numbers. But there's a lot of bills in Congress, which actually some of them were pre-COVID, that were talking about nursing home quality. And you can imagine that I'm sure they'll be getting a lot of attention now. So yeah, thanks, Jackie.
From Dr. Dalton, Kara Dalton, can you give us some insight on what organizations are doing to combat COVID-related burnout and the psychological distress for nurses who may be experiencing caring for patients in a pandemic for the first time in their careers? Yeah,
that's a great question. I think that from what I'm hearing, and actually I don't know if our dean is, Dr. Van Pelt is on the, I can't see, but there is work being done, especially with the hiring agencies, you know, dealing with, you know, stress and burnout. And there are a number of nursing organizations. I don't have names right here now, but I've been looking, like the American Academy of NPs and a number of other agencies that are doing work. I think the ANA or MNA was doing something as well. But it is a big issue. And I think, again, I'm not comparing the community nurses to the tertiary care nurses at all. But I do worry more about the community nurses because the resources for those agencies to do some of this stuff are not as great, but thank you for that question. It's important. And I do know in my own class, even as we were ending the semester, all of my students were on the front lines. And we spent time in class, and then we were on the Zoom, which I actually didn't mind that. I didn't know that I like to be right with my students, but it was fine. It was fine. And, but they were stressed, and we needed to give that, we needed to acknowledge that, and we needed to support that. And we need to be sure that they had some place to go to talk about it. So thank you.
Yeah, thanks, Janet. And I will add, just because Dr. Van Pelt is actually coming to guest in a course I'm teaching, and we created some resources for new incoming students who've been in the ICUs, that the Academy of Medicine has launched a huge effort to really, I think, look at this, burnout, distress, moral distress, et cetera. Yeah. And the ANA actually has some good resources as well.
I was on some of the earlier, there was a crisis resource allocation guidelines from the state that went out in March to be able to figure out who should get ventilators and ICU beds in case the hospitals were overwhelmed. And those discussions were really riveting and opened my eyes to, how would these guidelines read? Would they disadvantage lower SES, minorities, people with disabilities? But the biggest thing for the physicians that were on these calls was having to, they were not going to be asked to make those decisions. It would have to be a higher team doing that. They just could not, they were not, and they were even talking about having to maybe pull someone off the bench. It was just, they didn't want to have to be dealing with that, which I thought was a good thing. But that was an interesting time, to say the least.
So many facets of this. From Teresa Dean, many nurses and nurses aides who may work in the community are not paid effectively for the work they do. And if they're sick, they may not have the benefit of paid time off and not feel like they can take time off from work, even if they're sick. Also, public health nurses are paid by the municipalities that they work for, and many do not work full time. Yeah. So some comments about some of the barriers.
Right. Yeah, and we're finding that too with, like you said, CNAs, certified nursing assistants, and also PCAs, personal care attendants, who, many people lower, low income, not paid well at all. And a number of them were, positive, and, where do they go for, they don't have disability pay is what I'm trying to say. So it's a big issue.
Yeah. I'm on my local board of health. I was my public health nurse. I'm a DNP graduate from Northeastern in 2018.
Hey, congratulations.
Thank you. And my work was on the homeless children and families in their health care. But it's really challenging. My public health nurse in my local town works 18 hours a week. She sees over 100 patients who are homebound. We have a tremendous kind of grassroots support. That's been the wonderful thing. A lot of community involvement. Our senior centers, our headquarters, we do meal delivery. So there has been some really kind of community grassroots involvement of people rolling their sleeves up and giving back, which is great. But I think the other issue is, we don't know what the plan, COVID's going to be with us, and, what the long-term implications of this is going to be when, maybe some of our cases rise again and again, knowing about the vulnerable populations and what we can do and the lessons we've learned to really be able to protect them.
The lessons we've learned, I love that. Thank you for the work that you're doing. And go DNP grad, Northeastern. Yes, great. Oh, you do us proud. Thank you.
Jerry has got a question about family caregivers. So we had one. So let me pose that one, and then we'll tag right on to some of his comments, which we alluded to when we talked about the huge amount of money out that seems to be what costs families in lost earnings, et cetera, around caregiving. So during COVID, there were many adult daycare programs, senior day programs, school-based and respite programs for many citizens closed. What were the consequences for family caregivers? What did that look like, that experience?
Yeah, well, you know, I do know as far as the ARC work that we were very concerned about that because, you know, they're serving a lot of, again, frail adults with intellectual developmental disabilities, but also families that are caring for individuals with autism. And so when those day programs closed, it was a huge stress. And there were some school nurses who, we're talking adults over the age of 18. So if they were in school, some of the school nurses were actually able to come to the home and help some of the families. But it was a huge burden on the families, and it still is because they're home. And so a number of agencies did, you know, Zoom programs for if individuals could do that, for some individuals at work, for some it didn't, just like the school setting. So they did actually give individuals extra hours in some situations for caregiving. If they were on Mass Health, there were some accommodations made for if they didn't have PCA hours, then they could use home health 8 hours, but it still was extremely stressful, and they're still stressed because they're not back. The only day programs I really knew that were still open were some of the PACE initiatives, the Program for All-Inclusive Care for the Elderly. Some of them still remained open. But
yeah, and that kind of speaks to Jerry's comment about family caregivers really subsidize the healthcare system.
yes, definitely.
And
Many of them are working. You know, they're still working, or they're a lot older, like a couple that I know that live the next town over. They're in their late 70s, and their son is 39 years old, and he's full care. And they've been doing that solo during the days because he would have gone to the day program, and he's not there for 8 hours a day, and then sometimes now nights because some of their providers have gotten sick. So it's a huge burden. It's hard to, you know, hear these stories, but yeah.
A question from Dr. Kathy Hassey. Do you want to ask the question, or should I read it for you?
Thank you, Laura.
Hi, Kathy. Dr. Hassey from our School Health Academy.
Hi.
They're a national and international health academy, which is doing a lot of education, school nurses, but beyond that, across the country and international stuff too. So thank you, Kathy.
I think COVID has really shown the role of the school nurse. And thank you for putting schools in that community piece, because a lot of times people forget, you know, 26% of kids in school, and we have 1.2 million in Mass, have a medical diagnosis. So with COVID and reopening, it's going to be very interesting. A lot of the nurses have been working with their boards of health to do contact tracing. And yet some school nurses are being furloughed, and some, it's incredible. But they're paid with education funds, not healthcare funds. And that actually limits, you can have 20 years nursing experience, but you come in at step one. So that's been very difficult in school health. But can you imagine being one school nurse for 2,000 students plus faculty when school reopens? It's going to be, the reopening plans are kind of all over the place right now.
And you're the expert. You are the contact person. That's who they're going to go to.
And kids are going to get sick for reasons other than COVID. And we have a lot of faculty that are 60 or older or with conditions. So it's definitely a role that's going to be very important come September. But thank you for mentioning that role. And if I can just say, my mom, before she passed away, was part of a PACE program here in Worcester.
Which one?
It was at Summit.
Fallon, yes, I've toured that a few times.
We could not have kept her home for 5 years had we. PACE was, I kept saying, what's the bad side of this as a nurse?
Oh, I'm going to let Richard Burke know, the CEO. That's great. Thank you for sharing that.
Amazing. So those programs just have to continue for families.
I think they'll be expanding because of COVID. I think people are not going to want to go to nursing homes. So I think the PACE initiatives will expand. Yeah. And nursing is fundamental to PACE. There's no question.
And they were amazing.
Thanks, Kathy. Thank you. Thank you for sharing that about school nurses too. Thank you.
Let's see. A shout out from Joan W., a Bouvet class of 1980. I'm not going to try to pronounce the last name. Public school health and PE and dental hygienist. So she's just talking about prevention and the importance of that in community health.
Yeah. Thank you.
Heidi's the executive director of a 23-year-old, 100% nurse-led, peer-driven volunteer organization for women living with, affected by, and at risk for HIV. So there's that charity piece.
Yep.
She would, she would like to ask about, this very high-risk group, especially around COVID, and funding for this group and support is always challenging. Suggestions.
Yeah, I mean, they are very much at risk. And Dr. Rachel Jones, who's doing HIV NINR funded research in our department, I'm sure would love to talk with you. She's out there for prevention, trying to prevent, but I know, talking about people who are infected. And, I think that it's just, we have to, depending on just being, cautious and being sure that they're protected as best as we can. I don't really have any answers for that. I do know, people that are HIV positive and homeless have supports because of, like Boston Healthcare for the Homeless does a lot of work. But I'm not really up to date with other resources for, other individuals, unfortunately, with HIV. I should be, but I'm not. But thank you for that question.
It's an important group.
Yes, it is. It's huge.
As Congress has lifted some of the provisions for beneficiaries of fee-for-service Medicare, excuse me, the questions are coming in. Fee-for-service Medicare, especially regarding telehealth, telecare, telemedicine. Are you finding services are responding well with options for using technology? This is from Sarah Mosaday.
Oh, hi, Sarah. Where are you right now? Were you over where were you? She was in another country for a while. She's one of our adjunct instructors in the graduate program.
Hi, I'm in Spain.
Oh, you are? Oh, good. Well, good to see you in person.
It is you as well.
Now I'm going to remember your question. Oh, yeah. So the telehealth, that is huge. And actually, when we actually go through the challenges that the nurses faced, one of the biggest challenges, again, was access to care and not wanting to go to the emergency room. And my work at Fallon, too, same thing, that exponential use of telehealth across all providers, specialists, and primary care providers. There is absolutely, and obviously the payment was the initiative for that we got paid to do this work, right, via telehealth. And a lot of the nurse practitioners that are on our faculty are doing telehealth and getting reimbursed for that as well. I don't believe, I just can say right now, we have seen such success with telehealth. I can't imagine that we would go back, or there's certainly going to be some kind of tightening of the regulations, of course, but I cannot imagine. People with disabilities are very excited that they have this option now. I know with my own daughter, when she was starting to fail, driving her to Boston was just, almost impossible. Having that access was huge. But the physicians and the nurse practitioners and the PAs who are doing it now, and psychologists, and especially people in psych has been the boom in, telepsych has just grown too. So I have a feeling that we're going to be looking at, that's going to be the way it is. And it'll be a percent. I was just talking to one of the medical directors in Worcester, and they were saying that, it's going to be a good chunk of the care that they give will be provided that way. So I just had my physical 2 weeks ago, via telehealth, which is really interesting. But, as an NP, we were trained 75 to 80% of the patient's care, your diagnosis is what they say. So just hope they don't miss the other 20%. But I don't think a physical should always be telehealth, but I have boundaries, but I think it's just going to only grow. And it's a perfect opportunity for us because we started a virtual care continuing ed program that we're working on in Bouvet. And it's we can see now how important it is. So thanks, Sarah. Good to see you. Thank you for teaching our students. You do a great job.
Lots of great comments coming in through the chat, so I encourage all of you to really read them and maybe connect and reach out to each other. Let's see, Janet, one of the things I wanted to, we had talked about is a study that had come out regarding the within the state of Minnesota last year and was reported in the Journal of Pediatrics. And they looked at medically complex children. We haven't said too much about children, all of whom were discharged from hospitals needing home health. And the average child going home for the first time with an order for in-home nursing care spent nearly 54 additional days on average in the hospital due to the lack of in-home nurses to provide care after discharge. This is astounding from so many aspects. So maybe you could just talk in general, or what are some of the barriers to recruitment of nurses into community-based healthcare delivery? Yeah. And what needs to change? And I know we have mentioned that a little bit.
But yeah, I mean, think about the cost of 54 days in the hospital, and that would be definitely a high-paid home care nurse, right? I mean, for a whole year's worth of care, right? So, again, our symposium last June, where Secretary of Labor, Secretary Costa, also presented, was phenomenal. Lisa Duffy, one of our esteemed faculty, did the keynote, and she works over at Franciscan with special needs children as a pediatric NP. And they do end up staying at a place like Franciscan many times because, or at Mass General or at Children's, because there's no care back home. A lot of these children are on ventilators, and so unless you've got highly trained nurses that can do this work out in the community, and we're seeing more of these children. We keep, children that are born premature, and we just are able to keep, they've got better care. So the problems are, I think, the biggest thing is awareness, first of all, of the opportunities in home care, and that is huge. We do not do a good job, and I'm going to put us in there too, of preparing our nurses outside of tertiary care in general. I mean, Catherine O'Connor is an angel on earth who's got the homeless van which Bouvet supports, and she takes students out, and we do a lot with the homeless, which is incredible. So that piece is huge. But in general, the home care situation, we just don't. There's some barriers to that too. So there's lack of knowledge that it's an opportunity. There's, again, the factor of isolation and the pay. The pay is different. The pay, if you work at, Mass General or even a community hospital, is going to be more than you're going to get paid hourly with a home care case. I have been working with LPN programs to see if we can get, because some of my best nurses, frankly, hands-on, stellar nurses in my home were licensed practical nurses because they were able to do the technical stuff. They were just really, a few of them were really good. They were very seasoned. So why aren't we looking at that also as an option for some of, we just need to really increase awareness. We need to pull together nursing agencies and nursing schools so there's a collaboration. Some of the regulations with the Board of Nursing, I've been to meet with the executive director of the Board of Nursing, can actually inhibit that because they need to be bachelor prepared preceptors for any level of nursing preceptorship. So that's an issue.
So how do you, kind of moving off of that, how is Northeastern, Bouvet College in particular, positioned to prepare our healthcare providers, nurses, physical therapists, pharmacists, public health professionals, speech and language, and if I forgot anybody, the whole team?
Yeah, no, well, I don't want to forget anything here, so I've got a couple of notes. I do want to actually just talk about, we should talk just after this, Laura, about just the challenges for COVID in the settings.
Yeah.
But right now, let me just talk about, how Northeastern is positioned. We have strong community rotations for our nursing students, the NP students, if they're in primary care, or some even acute, are in community settings and rotations. So we're doing, a great job with that, and I think we could do more with home care. We had, I mentioned already, the home care symposium in June, where we're getting government visibility. Secretary Sutters, the Massachusetts Executive Office for Health and Human Services, the secretary, told me she would come, and we had a date, the end of May. We were going to bring all the nursing programs in the state to Northeastern to talk about the community care crisis. And she was going to talk to them about some of the needs and So high visibility from the from the secretary. So she's over everything. So we're making those connections, and hopefully we'll get her maybe, I'm not quite sure when, we should probably safely do it, but it'll probably be the beginning of next year. We have our virtual care telehealth continuing education project that Carmen Shepa, Dean Shepa, has been a huge proponent of this, that we hope that we can roll out soon, that will give healthcare professionals education in virtual care. Dr. Rachel Jones, I mentioned her doing HIV research and INR funded research. Dr. Kale Guyan is doing HPV-associated cancer prevention among African Americans. And Lisa Duffy is doing family-centered management of children and adolescents in the community with special needs. We've already talked about Catherine O'Connor's van. I mean, I'm speechless when I talk about all we're doing. Matthew Goodwin, I want to mention him in Beauvais, is doing research with a colleague from Matthew Siegel, I think his name is, from Maine Health and Tufts. They're looking at autism and early, which I think is fascinating, early from looking at biomarkers for the potential for increasing agitation and aggression, and behaviors, so that families can keep their loved one at home. If you could intercede early, wouldn't that be a huge gift? And I see Kathy Hassey shaking her head, because school nurses would love that too, wouldn't they? So that's huge, and my hat goes off to his research. And we all know, well, we don't know maybe, but many of us know about Dr. Holly Jimison and Mishu Pavel's research on home sensors to keep frail elders at home and using sensors. So our future research, I see huge possibilities for, again, telehealth. I think every home of the future, I'm going to my future now, but I can't help myself, will have this little box in their home, and it'll have blood pressure monitoring and all the things you monitor, EKG and everything. It'll just come with the house. So you'll have it with your cable TV, and you'll rent it, and it'll be part of whatever, every home. And it'll be set up that there'll be monitoring for anyone that would need that. And it'll go to a central location, and your health insurer or your health provider would have, you'd be able to do that if you needed it to stay home. There's a huge potential for robotics in home care. Huge. We've also been looking at robotics in day programs and in group homes. We had a company come out, maybe 3 years ago, they came into my office with the robot, so we could look at how it would impact care within the day programs in the group homes. And I am not saying that replaces nursing or care. It does not. But I'm just talking about things we can do in the future that, Northeastern and Beauvais can be a part of for research, but also rolling out. So anyway, yeah.
Well, that's, again, some great comments in the chat section. I don't see any more questions. We have about 2 minutes left. Is there any?
Is it only 2 minutes? Oh, really?
Yes, only 2 minutes. That's why I wanted to get
Oh, I'm sorry. Dean Shepa, you were so right. An hour wasn't enough. Can we I really do want to talk really quickly about the challenges for the nurses in the community, though. Testing was a huge problem, and home care nurses were not considered first responders either for testing, I was shocked. PPE, a comment, I went out to Ocean State Job Lot and I bought 80 rain ponchos for gowns. That was a nurse in long-term care. A nursing director for those with serious mental illness hired a seamstress to make cloth masks. Patient family staff education, again, educating families that they can't come in, and they can't come in when their family member's dying, into the nursing home and the assisted living, the group homes were a little less strict about that. Just infection control guidelines and where the information was coming from. Ethical dilemmas, who gets the PPE and what kind of PPE should they get? Who gets tested and when? Stress, patients dying without their family. I felt I had no time to mourn and grieve. I felt isolated myself. It was isolation for me as well. Tracking cases, access again, and then again, the staffing issue.
Yeah, wow. Amazing. Well, let's see. Any other questions or comments, Janet? Do you want to?
That went way too fast.
Yeah,
way too fast.
Yeah. some amazing, amazing comments, work. I mean, the multitude of the populations out there that we care for in the community. It is complex, and definitely needs an increased resources, attention, and it needs nurses, more of them.
And more training of nurses for community settings to be doing really intense medical and nursing work outside of tertiary care.
Yeah.
So, yeah.
So I said I wouldn't come back in, but I just want to thank you both, Janet and Laura, for a great conversation, and for all of our 60-some and still 53 participants at 2 p.m. Crosby is going to put on the chat our next speaker series, which is on July 16, and we will be then feature also some of our great alums from nursing and health sciences. And so stay tuned for the communication. It will be on July 16. And thank you so much for all your expertise and your wealth of information and experience, Janet. It is really an absolute delight, and I'm so proud of be the dean of a college that has the caliber of human beings and faculty like you.
Well, thank you, Dean Shepard, for this opportunity. I just was so excited. So, and Laura, thank you so much for moderating. I so appreciate that. Everybody, thank you so much.
Thank you, everybody.
Have a great day, everyone.